My name is Erin Moscoviak, and this is my final presentation. A little bit of background about my case study. My client's name is Mark, and he is an 11th grader struggling with internet addiction. He was adopted from Romania, and he has been claiming that he has many friends online that understand the feelings of being adopted or the feelings associated with being adopted better than his friends in real life. And he talks about his online friends as if he is spending time with them every day in person. He is also isolating himself from his family and friends, and so he's avoiding interaction with any of them. He no longer spends time with his cousin that he used to spend time with every day. And recently, he has refused to come out of his room to eat meals with the family. He is also failing all of his classes. He received an in-school suspension for talking with an online friend during class. His parents have recently found cigarettes and a lighter in his backpack, and he denied that they were his. And his mother has also reported that he has been very tired and lethargic. So the first treatment option for Mark is cognitive behavioral therapy internet addiction, CBTIA. This was created by Dr. Kimberly Young. It was significantly influenced by CBT while also incorporating harm reduction therapy. The 3 stages are behavior modification, cognitive restructuring, and harm reduction therapy. So, stage 1, behavior modification, emphasizes identifying the issue and setting goals to create a healthier pattern of use. The counselor will have the client keep a journal for 2 weeks to record each time they access the internet, and this is to help the client recognize they are using it excessively. And so this would be especially important for Mark since he is not currently able to recognize that he has a problem with using the internet. Also, you want to include events that led to the use of the internet within this journal, the amount of time spent online, and the events following or related consequences. And so Mark would want to make sure to include that he received an in-school suspension for being online in class. And then, so overall, eliminating the internet as a whole is really not realistic. And so a technique that is implemented into this first stage is just the use of parental locks and also an accountability partner to check in with the client and make sure that they are staying on track. So, stage 2 is cognitive restructuring. This is identifying, processing, and reframing the client's thought patterns. The goal here is to help the client gain a deeper understanding of why they are using the internet, which could be related to avoidance or other situations and feelings. So once that thought pattern is established, the counselor will encourage the client to challenge those beliefs. And this may be a very difficult thing for the client, considering that they have just recognized that they even have an issue regarding their internet use. And so it's important for the counselor to maintain a positive environment because the client may not believe that they have the ability to change. And it's the counselor's job to encourage and maintain that positive, uplifting environment where they are encouraging them that they do have the ability to change. And then phase 3 is harm reduction therapy. This addresses the remaining behaviors that may be negatively impacting the client's life. So, for example, a client may need to work on interpersonal relationship skills if they've isolated themselves from their family and friends, like Mark has. So that may be something he would work on in stage 3. And the 2 goals within harm reduction therapy are to identify the core problem and implement healthy and effective coping strategies. So some examples of techniques for CBTIA: practicing the opposite, establish external stoppers, set realistic goals, reminder cards, and family therapy. And I'm going to go over a few of them. So practicing the opposite, like I said before, it would normally look like completely not using the internet, but that's not a realistic goal or strategy. And so this would look more so like limiting time spent on the internet. And that may also include a schedule that was created and agreed upon between the counselor and client during session. Also, setting realistic goals is always important because this is going to help the client not be set up for failure, but also it could avoid significant withdrawal side effects. And then family therapy is a key component of treatment, since the individuals struggling with internet addiction will often isolate themselves from their family, like I've said. And so this is a chance for the client to rebuild their support system while also having the opportunity to express to their family how each of them can help during recovery. Some benefits and limitations of CBTIA. The first benefit is that it is specifically created for internet addiction, so it works really well with this case study. It's very structured and easy to follow. It is a 3-month treatment plan, which, although it doesn't seem like a very long-term treatment, it is a longer term than the second treatment option I will be talking about. It focuses on integrating back into normal life, which is so important for the client. And so it's using the techniques and interventions and things talked about during session, practicing them outside of session to be able to help the client integrate back into their day-to-day. It is a directive approach, which could be a benefit or limitation depending on the client or counselor, but for this, I think it is a benefit. And also, it's bringing awareness to the client's behavior, which is positive, and it's goal-oriented with the goals being created by the client. A couple limitations: it focuses more on techniques and interventions versus the client's presenting emotions. And so although the emotions may be something that are brought up during session and can be talked about, CBTIA is really more focused on the behavioral aspect of treatment. And a limitation: although it's a benefit, it can be used for internet addiction, it's a limitation that it can only be used for internet addiction because it's such a specific treatment structure. So a little bit more about CBTIA. It is 12 weekly sessions or 3 months long of treatment. And studies have revealed that it may be most effective within the adolescent population. But some other necessary components were psychoeducation for the adolescent, but also for the family, so that everyone is understanding internet addiction as a whole, but also that everyone's on the same page with the treatment plan. And then the use of motivational interviewing with CBTIA was also recommended to increase effectiveness, and I'm going to be talking a little bit more about motivational interviewing in a little bit. Overall, though, there needs to be more information to state that this is the overall most effective treatment for internet addiction. And so there currently is a lacking in studies and enough evidence to say that this is for sure the most effective, but most studies have revealed that CBT in general has been most effective for internet addiction. But overall, there still needs to be more information. And then the counselor's role in therapy is to guide the client by implementing strategies during each phase and then helping the client reframe the thought patterns. And then the client is to follow the guidelines of the counselor throughout treatment and complete the homework assignments given. When researching CBTIA ethical and cultural considerations, I found that there was little to no research regarding CBTIA specifically. And so I'm going to talk more about CBT overall. And then these are just some things to be mindful of with any treatment. How the client views therapy, how the client's family and friends view therapy, cultural ideas around talking to someone outside of the family, and then views of medication management if that is something that the client needs. The first three here are also ones that you want to consider with all treatment options. So the first, consider the client's culture and past experiences when choosing interventions. Also, something that's really beneficial for the counselor is always psychoeducation for themselves regarding history, culture, values, etc. of the client's culture. And this can be done within the session or outside of the session. Within the session, it may look like the client opening up the conversation and wanting to teach the counselor. But if this is just not the case, or they're not comfortable, or whatever it may be, this can always be done outside of session on their own time and their own research. And then some barriers that you want to consider for the client. They might be dealing with barriers such as healthcare, their job, social injustices, discrimination, microaggressions. So again, you just want to be mindful of how you talk about the client's culture and how you conduct therapy and what interventions you choose. You just want to always have the ethical and cultural considerations in the back of your mind. And then specifically for CBT, the cognitive restructuring aspect is going to be a little bit different. And so normally cognitive restructuring includes that the client has some sort of irrational thought pattern, irrational belief, irrational fear, something that's irrational. And so considering your client's background, you want to acknowledge that their thought patterns may actually not be irrational given their circumstances. And so acknowledging the client's experience and their emotions associated with it, letting them to openly and freely talk about their experience, while not being like, this is irrational, we need to reframe it. And so just being more open to the idea that if they have experienced discrimination or whatever it may be, their irrational is not irrational. To us, to the counselor, it may seem irrational, but that's because we don't have a shared experience. And so just being mindful that what they're saying is just their reality and it's not irrational. And so cognitive restructuring may look a little different. It may be more so restructuring their thought pattern or their belief about themselves, or their belief about the entire world because of how they've been treated or what they've experienced. Treatment option 2 from Mark is motivational interviewing. This was created by William R. Miller and Stephen Rolnick. It emphasizes the ambivalence to change within a client and the idea of balancing pros and cons to a situation. And so there are 4 pillars: partnership, acceptance, compassion, and evocation. Partnership includes the idea of using a collaborative approach and working together with the client rather than the client and counselor being separate. Acceptance is understanding the worth of the client and bringing a non-judgmental perspective to each session. Compassion is prioritizing the client's needs and advocating for them when necessary. And evocation is using the partnership built within the first pillar to work with the client to evoke what is needed to create and maintain change in their life. And so some techniques here are expressing empathy, developing a discrepancy, rolling with resistance, and supporting self-efficacy. So the first, expressing empathy, is accepting the client for who they are and utilizing reflective listening skills to portray your genuine empathy toward them as the counselor. Developing a discrepancy encourages the client to be able to see the difference between goals they have set and behaviors they are participating in. So it's also bringing awareness to potential consequences regarding their current behavior. Rolling with resistance is avoiding arguments with the client and acknowledging the importance of the client's story and perspective while offering possible alternatives. And supporting self-efficacy is cultivating a genuinely hopeful and optimistic space for the client to receive affirmation from the counselor and begin to create change in their lives. Some benefits and limitations for motivational interviewing. So, benefits, it focuses on the client's feelings during each stage of treatment. Again, it is directive, it brings awareness to the client's behavior, it is goal-oriented, where the goals are created by the client, and overall, it is a client-centered treatment approach. Some limitations. This is a very brief short-term treatment for addiction, and for this case study specifically, a limitation is that it's not specifically structured for internet addiction. Not saying it wouldn't be effective, but just saying it's not as structured specifically for the addiction as is CBTIA. And then it's also more focused on the work being done during session between the counselor and the client versus work being done outside of session. And so it doesn't emphasize as much getting the client back into their normal life. A little bit more about motivational interviewing. So like I said, it's a very brief treatment option. It is about 2 to 4 sessions, so very quick. It was first introduced to assess the client's readiness to change, and then as it was developed, the term ambivalence to change and balancing pros and cons of a situation were aspects that were added to the approach. So now it is all-encompassing of all of those things. The client or the counselor's role is to identify discrepancies between what the client is saying versus the client's goals. The client's role is to follow direction of the counselor and discuss both sides, positive and negative, of change. So another way of saying this is the counselor's role is to shift the client's perspective, and then the client's role is to talk about the positive and negative sides of change. But it's also important for the counselor to encourage the client to talk about both sides while not strengthening either side. So the client is not saying, oh, this is better than this and this is better than this. They're just talking about the positive and the negative, not compared to each other. So it's a very neutral conversation. This is an approach that works well for substance abuse treatment. It's a collaborative approach, and regarding relapse, it can be used to plan for relapse, or it can be used in the beginning stages of relapse, treatment for relapse. And so it motivates the client to begin treatment within the early stages of relapse. The client will want to think through their previous plan that did not work and develop a new plan and then start that new plan. Motivational interviewing, ethical and cultural considerations. So, motivational interviewing has been seen as manipulative. It's been described as the counselor persuading a client to change something they may not be ready to. Now, this is not to say that every counselor who uses motivational interviewing is manipulative and persuading the client into something they don't want, but it's something to be mindful of and a critique that has been made. Also, there have been issues with informed consent, and so some counselors, when using motivational interviewing, will begin with inviting the client to talk about an issue without discussing their intention to explore the client's readiness for change. This, again, can be simply fixed by adding in informed consent in the beginning, which I'm sure many counselors do, but it's also something that obviously some counselors do not, and so there is an issue with that. And then it may not be ethically appropriate for a client who does not have the capacity to explore the pros and cons of the situation. And so this is if you have a client who has low intellectual functioning or possibly psychosis that has decreased their insight. You just want to be mindful of if you're using the appropriate approach and if the client is going to be fully capable of participating. Overall, motivational interviewing has been described as culturally sensitive because of the aspects of it being client-centered, non-judgmental, and based on the client's own beliefs and understandings. And again, like I've said before, you always want to consider how the client views therapy, how the client's family and friends view therapy, cultural ideas around talking to someone outside of the family, and the views on medication. Comparing and contrasting CBT-IA and motivational interviewing. So, some similarities, like I've said previously, they're both directive, they both bring awareness to the client's behavior, they both have goals created by the client and are overall goal-oriented treatment approaches. And they both emphasize utilizing realistic goals, which is really important so the client does not get set up for failure. And they're both very structured approaches. So they have a structure, they have the stages or the pillars that a counselor can adhere to pretty easily. Some of the differences. So CBT-IA is obviously longer. It is a 3-month treatment versus 2 to 4 sessions in motivational interviewing. Also, CBT-IA is structured specifically for internet addiction and includes interventions to create a healthier pattern of use, whereas motivational interviewing is not structured specifically for any specific addiction, but that does not mean that it wouldn't be beneficial. It's just not as specific, especially in its interventions. And then motivational interviewing is also more client-centered. Also, CBT-IA emphasizes integrating back into normal life and rebuilding a support system, whereas motivational interviewing is more focused on the work being done within session between the client and the counselor. Also, motivational interviewing is more focused on the client's emotions during each stage of treatment, and CBT-IA is more focused on the behavioral aspect of treatment. And so that also goes back to motivational interviewing being more focused on within the session, how the client's feeling during each stage in the present moment, whereas CBT-IA is more behavioral, going out, practicing the techniques, integrating them into your life, and getting back into your day-to-day. So overall, I think that Mark's diagnosis currently could be unspecified adjustment disorder. And I'm going to go over a little bit about the rationale behind this. So the reasoning that he gives behind being on the internet is related to his adoption or his feelings associated with being adopted. And so that makes me think that there may be some issues with adjusting to the adoption within that. Now, I don't know if he was adopted like recently or if it was in the past, but either way, he is associating the internet with his feelings with adoption. So that makes me think there's some adjustment. Also, there is for sure impairment in social and educational areas of functioning. So with social, obviously he's isolating himself from family and friends, and he's refusing to eat meals with the family. He is no longer spending time with his cousin he saw every day, so that type of thing is definitely impaired. And then educational areas of functioning seem to be impaired because he has started failing all of his classes. So those two areas of functioning are impaired. A couple other criteria for unspecified adjustment disorder is that the client does not meet full criteria for any other mental health disorder, which Mark currently does not. And his behavior and emotions are not related to bereavement, which, as far as I know, they are not. And then for unspecified, or for adjustment disorder in general, there are specifiers. And so I chose unspecified because I don't feel that I had enough information provided to confidently identify anxiety or depression symptoms. And then there's also another specifier of conduct and a couple others, but I felt that I just didn't have enough information, so I just went with unspecified. And that kind of goes along with, obviously, with this case study or with any of our case studies, we have not met the clients. We have not evaluated them in person, gotten to know them. We just have a paragraph of information regarding their situation. And so we can't accurately diagnose them anyway. But with the information that I have, I am going to go with unspecified adjustment disorder for the time being. That being said, there are for sure diagnostic rule-outs. So the first being obsessive compulsive disorder. And so with OCD, there is the preceding intrusive, unwanted thoughts that are going to compel the client to partake in a compulsion that is either going to make them feel better, make those thoughts go away, a whole different slew of things that they could be thinking. And so for Mark, it makes me think he has a lot of repeated behavior on the internet, and I would want to know more about his thought patterns prior to going on the internet. If he has those preceding intrusive and unwanted thoughts that are making him feel really bad or really nervous or whatever it may be, and that he's using the internet as a coping strategy, as his compulsion, I would just want to know more about that before ruling it out. And then also, the last one is other or unknown substance abuse disorder. And I used this one because he does meet 5 of the 12 criteria for this, which does put him in the moderate severity level. And so those 5 criteria that he meets are increased use of the internet, increased desire to use the internet, his grades are dropping, he's isolating himself from others, the majority of his time is spent on the internet. And so, like I said, that puts him in other unknown substance abuse disorder, moderate. So that's just something to be mindful of if someone is in, the moderate level of a disorder. You definitely want to look into it. The 2 things that he does not meet for this disorder is that, 1, internet is not considered a substance, so I don't believe that he could actually be diagnosed with this. I'm not sure, but it depends. I mean, right now, internet, I don't believe is considered a substance. And also, another thing that the client must have to get diagnosed with this is that they recognize that their internet use is an issue, or their substance use is an issue. And so this would be difficult with Mark because without treatment right now, he does not recognize that there is an issue and he is not able to identify an issue. Therefore, he could not currently be diagnosed with that either. But these are 2 very important things to consider before making a diagnosis overall. In this last slide, I have just listed all of my references.